Good morning, and thank you, Mr. Chairman, and thank you to the societies to make this opportunity and interaction possible. So I'm going to start by showing you these photos, which really depicts one of the dilemmas that we face when dealing with heart valve surgery in a third country, where we really live on the interface of first and third world environments. Now, these pictures were taken in Cape Town, where we practice. It's a 20-minute drive, basically, the environment that we see on both sides of the mountain. And it's this classic diversity that also spills over to our patient populations and the cardiac surgical practice that we have to deal with. And I would like to share with you a certain subset of these patients, and those are the patients suffering from rheumatic heart disease in need of an aortic valve replacement. Now, at first glance, the choice of therapy or the treatment might seem very obvious, but once we delve a little bit deeper into this whole dilemma, we see that it's actually much more complex. So we did a retrospective review over 10 years ending 2013 of all patients who had a surgical aortic valve intervention at our unit, and then excluded all those patients who had root replacements, concomitant surgery, or any redo procedures, which left us with a cohort of 306 patients who had an isolated first-time surgical aortic valve replacement. We then further subdivided the cohort according to the underlying valve pathology. Now, on the left hand of the pie chart, you will see the patients more familiar with in first world countries in red and green. These are calcific degenerative and also the bicuspid valves. And on the right-hand side of the curve, which presents more than 50% of our practice, are patients suffering from rheumatic heart disease, also those with endocarditis, which predominantly have an underlying rheumatic heart valve pathology. And I will focus on these patients. So just to introduce you to the patient subset, this is a few slides on preoperative baseline demographics. Firstly, the big difference is that these rheumatic heart patients that present for surgery are much younger than conventional first world patients. In fact, the mean age is about 45, compared to first world patients presenting in their 6th or 7th decade. In terms of gender distribution, once again, there's a difference. The majority of patients with rheumatic heart disease are male, in fact 2/3 of them, but also then on the other side, bear in mind that a lot of the females are also still in childbearing, at an age of childbearing years. With regards to the valve lesions, once again there's a big difference. First world patients present with stenosis. Our patients present with a mixed valve lesion, which is predominantly incompetence. So what does a typical patient look like that we are faced with? It's a young patient. In 2/3 of cases, it's a male. Mixed valve lesions, predominantly incompetence, class 2 or 3 symptoms at presentation, preserved LVs, and usually no major comorbidities. So you would ask, what's the problem? It seems like very straightforward surgery. Yes, it is. Actually, if you look at the predicted surgery, a surgical risk for these patients, for example, looking at the STS score, it's very low. It's less than 1%. So these are the challenges. The first challenge are that these valves are fairly seldomly repairable. This is due to the mixed pathology, but also due to the fact that a really true, lifelong, durable repair for rheumatic aortic valves is rather the exception than it is the rule. These patients also have very unique socioeconomic circumstances. In the green bars show patients who have not finished secondary education or school education. This then translates into unemployment rates. In the blue bars, 75% of these patients do not have any form of employment. And these factors together contribute to the challenges not only when dealing with anticoagulation, but also in terms of patients' follow-up, because a lot of the patients simply don't have the means to get back to hospitals or clinics after the surgery has been done. And then the last problem is that of prosthesis selection. Now, what does the guideline say, taking into consideration that there's no perfect valve substitute, and whatever you choose, you're going to introduce a new disease process into the patient? Well, broadly, the American guidelines use 60 and 70 years as cutoffs for mechanical and bioprosthesis, and the European guidelines focus a little bit more on the individual patient. But even with this approach, both guidelines will still recommend, in most cases of the patients that we are dealing with, to insert a mechanical prosthesis. What have we done during this period? Well, simply stated, we have followed the guidelines. In the rheumatic group, the majority of cases shown in the blue bar received a mechanical prosthesis. That was 90% of the group, compared to what's fairly normal, more liberal use of bioprosthesis in the first world patients. This just shows you a breakdown of which prosthesis we have used, both mechanical and bioprosthetic, which just shows non-biased use of all the prosthesis, which is typical for a university hospital. These are the short-term results, nothing special there. Operative and 30-day mortality was 2.5%, and you can see in the complication column there, nothing that really stands out, everything on par. So here's where the problem comes in, it's during the follow-up. For this specific series, our mean follow-up was 6.1 years. Follow-up was 97% complete. And the two primary outcomes that we looked at was survival and valve-related morbidity. I start with the valve-related morbidities. On the graph on the left-hand side, I'll show you certain valve-related or freedom from these morbidities, and on the x-axis follow-up in years. We were more interested in the mechanical prosthesis, so they are depicted in the blue lines. Nevertheless, added the small cohort of bioprosthetic valves in the somatic group as well. But I must state this is not propensity match, it's not randomized, it's merely a retrospective review or audit what has happened. So when we look at bleeding, and bleeding is defined as any event that causes death or readmission to hospital or blood transfusion, our freedom at 5 years and 10 years for the rheumatic cohort receiving a mechanical prosthesis was 95% and 95% at 5 and 10 years respectively. Looking at freedom from embolism, this is stroke and TIAs. In the mechanical group, freedom from this valve-related morbidity was 98% and 96% respectively at the two follow-up periods. Then the composite of bleeding embolism, which really reflects the difficulty in dealing with anticoagulation, was 92% and 91% respectively at 5 and 10 years. Then we added to this composite also the other valve-related morbidities, including structural valve dysfunction and non-structural valve dysfunction, and also thrombosis. And when we look at this data, the freedom from all these valve-related events was 92% and 89% at 5 and 10 years respectively in the mechanical group. Freedom from reoperation, again 96 and 95%. So it's clear that these patients who received a mechanical aortic valve prosthesis have a low but yet a constant risk of valve-related morbidities during a fairly short follow-up period. But what I show you next is where the real problem lies, and this is survival. This graph shows the overall survival of patients who received a mechanical prosthesis, and it's only 86% at 5 years and 78% at 10 years. Let me remind you, these are patients who are in their mid-40s, and it's follow-up only during the first decade after receiving their prosthesis. It's therefore no wonder that these survival rates are much lower than our age and gender matched population in Cape Town, and also I've noticed that these mortality rates, 90% of them are actually cardiac or valve-related. Just for interest's sake, I put the bioprosthetic valves in. There was one early death during the first 30 days, and these late three deaths were all due to cancer, so non-cardiac or non-valve related. Then lastly, we looked at MACE, so freedom from all major adverse cardiac events, which include valve and cardiac related mortalities, valve related morbidities, and also those who needed a pacemaker. And this is really concerning on the bottom right here. In the mechanical group, 5-year freedom from any of these events is only 75%, and at 10 years, 67%. So clearly this promise that a mechanical prosthesis is a lifelong companion is not true, and perhaps we should rather, when we take consent, at least for our patients, indicate to them that they in reality probably have a 1 in 3 or 1 in 4 chance to have a real major event during the first 10 years after their prosthesis implant. So in conclusion, when dealing with rheumatic aortic valve disease, these valves are very seldom repairable. We have to usually replace the valve. It doesn't matter really what you choose, whether it's a tissue valve or a mechanical valve, or homograph or autograft. In reality, you will have to be faced with two problems. If you choose tissue, you're going to at some stage come back. If you choose mechanical, patients will be exposed to a low but constant risk of valve-related morbidity, but even more worrying, very suboptimal survival rates, of which in most cases, or 90% of cases, these mortalities are valve and cardiac related. So perhaps the time has come, at least in our practice, to revisit the liberal use of mechanical prosthesis and rather look at alternative solutions, perhaps looking at multiple interventions or planned re-interventions, which can include surgery and both transcatheter techniques to try and address the suboptimal rates that we find in this subset of population. Thank you very much.